today's panel on vaccine hesitancy. Whether you're joining us in person or virtually, we appreciate you taking the time to attend this session, listen to the discussion about this important issue. I'm Trevor Hedberg, a postdoctoral scholar jointly affiliated with the College of Pharmacy and the Center for Ethics and Human Values, who are both co-sponsoring the event. It was slightly over 2 years ago that here at Ohio State we sort of shut down things on campus and started doing everything remotely, including events like this and all of our courses because of the COVID-19 pandemic. But now we've been able to go back to in-person events and teaching because over 90% of the Ohio student body is vaccinated and vaccinated fully, had all 3 of the recommended shots. But vaccination rates aren't as high everywhere in the United States, including here in Ohio, where only about 62% of the state has had even their first shot in the series, and only around 57% have completed the full sequence. That doesn't rank great as far as the United States as a whole goes, and it doesn't come anywhere near as close to the benefits of herd immunity that we enjoy here on campus. So this raises some interesting questions about efforts to get the public vaccinated. One way we can do this, of course, is to try to make it mandatory via mandates imposed by universities or employees or other organizations. But it's worth considering whether or not there are alternatives that are less coercive. Mandates have costs, not only in terms of breaching people's personal autonomy, but also in terms of their effectiveness. There tends to be a significant pushback. There are lots of instances where people will rebel against vaccine mandates for a wide variety of personal and political reasons. So this panel focuses a little bit more on a less coercive measure, specifically nudges, an alternative way of trying to persuade people to get vaccinated. And we're going to assess, the panelists are going to speak about the effectiveness of those measures and how they compare maybe in terms of pros and cons to other both coercive and non-coercive measures. So our panelists today consist of 2 people from Ohio State and our visiting speaker, who I will introduce first. I'm delighted to introduce Dr. Mark Navin, who is the professor and chair of the philosophy department at Oakland University, as well as a lecturer in the Department of Foundational Medical Studies at Oakland University William Valmont School of Medicine, that is a mouthful, and a clinical ethicist at Valmont Health. He's published a lot of articles in the most prominent journals in medical ethics, and perhaps most notably for our purposes, is the sole author of the monograph, Values in Vaccine Refusal, Hard Questions in Ethics, Epistemology, and Healthcare, a book that was published by Religion in 2016. For our commentators, who will offer some critical remarks or perhaps constructive remarks on Mark's presentation, we have Dr. Miriam Shaw here for seated in the middle in between Mark and Kristen. Miriam is an assistant professor in the College of Pharmacy and the director of Pharmacy Extension and Public Health Initiatives. Prior to joining Ohio State in 2021, she was the Pharmacy Policy and Innovation Fellow for the Ohio Pharmacists Association. And our other commentator is Kristen Carpenter, who is a clinical health psychologist and associate professor in the Department of Psychiatry and Behavioral Health, Psychology, and Obstetrics and Gynecology here at Ohio State. She's also a member of the Ohio State Comprehensive Cancer Center and director of ambulatory services for Ohio State Harding Behavioral Health. So some of you all have way more interesting titles than me. Just to post up. So in a moment, I will turn things over to Mark to deliver our main presentation. And afterwards, Kristen and Miriam will provide their comments. I'll then chime in with a few questions to get our discussion going, and we'll close with whatever time we have left to take questions from the audience. Again, I thank you all for coming out today and attending. Without further ado, I will turn things over to Mark for his presentation, Pro-Vaccination Nudges and Conflicts Between the Ethics of the Clinic and the Public Health.
Great, thank you so much, Trevor. I'll turn this microphone off if I can. Very good. Thanks for that warm introduction. Thanks for having me on campus today, my first time in Columbus. It's been very pretty today. Thanks also to Pam and Piers and Kate for the warm welcome. And I'm delighted that Chris and Miriam are going to give us both their sort of science and public policy expertise to bear on some of these questions that maybe I'm addressing from more of an ethics point of view. My recent work has really been on vaccine mandates, coming out of Oxford on politicized battles about vaccine mandates. So I'm delighted today to try and take a step back, as Trevor suggests, to a place we go to in public policy and in clinic before coercion, but is nonetheless either bypassing or otherwise not acting directly on people's rational decision making, which we'll discuss about in the context of nudges. I want to motivate the talk, before we even get into it, by on the one hand, as Trevor suggests, this worry about avoiding coercive public health policies, which would include mandates. But also motivate the other side of it, which is a kind of conflict of moral vocabularies, which are ordinarily applied in what I think is generally non-overlapping areas. And so I think that is to say about the ethics of public health, which emphasizes population level good health outcomes. And while it is attentive often to avoiding violations of liberty, is this not working? Is less, I think I am, the battery. Yeah, am I there? No, it is dead. Test, yeah, I think that microphone's dead. Hold on. Thanks, is that working? Good. So I think, in general, the ethics of public health attending to population level health outcomes, and while attentive to avoiding violations of individual liberty, much less concerned, right, with doing so, and with often granting permission to do so, and in particular less concerned about questions of autonomous decision making, at least as a primary concern. So, for example, we are quite content, I think, with government or employers using all kinds of persuasive and even manipulative means to get people to wash their hands before returning to work. We're okay with laws that even put people in prison if they're dumping toxins in our drinking water sources. These are quite normal ways of thinking about the ethics of public health. In contrast, the ethics of clinic has as its chief value informed consent. That is to say that capacitated patients who are acting voluntarily with adequate information, making what look like more or less autonomous judgments. And while we might want people to make different judgments we think are better for themselves or better for the community, in clinic, we really do prioritize, right, in clinical ethics, the autonomous judgment of the individual. I think that many of the conflicts we're having with vaccine mandates are illustrations of one place where these two generally non-overlapping magisteria are overlapping, namely vaccination, which is both a personal medical choice and a core component of public health. And I think if you're paying attention to anti-mandate protests, we'll see people with signs saying, you know, my body, my choice, right? Or even invoking the horrific abuses of Holocaust medical experiments. I think wrongly so on both counts, but both of those kind of illustrations show people invoking something closer to the ethics of clinic in the context of what to others look like straightforwardly public health context. So I'm happy to talk about mandates as a deeper example of this conflict. I actually think some of the ethics discussions about nudges also are an illustration of a similar kind of conflict. That's what I kind of want to walk into today. So let's, yeah, no one's paying me. As I say, please, I would love some money. So one thing that motivates me to think about nudges is the alternatives are so bad. In particular, there's two kinds of policies that I think have become more mainstream in governing immunization noncompliance, both in clinic and in society. And here I'm thinking about the last decade and a half for routine childhood immunization, definitely accelerating in the past 6 or 7 years. And that's dismissing vaccine refusers from clinic, which is, I'll say in a minute, upwards of 50% of pediatricians are doing that now, and eliminating non-medical exemptions to school and daycare vaccine enrollment requirements, which is now the consensus position of the American Academy of Pediatrics, the American Medical Association, frankly, all major physicians' organizations, and has been a top priority for their state lobbying efforts across the country. And we've seen 4 or 5 states actually move on this. In fact, I'm happy to talk about it later. I think there's a direct connection between that battle and politicized COVID-19, both disease mitigation efforts and vaccine policy rollout. I think both these kind of policies have good intentions, but I think they are bad in lots of ways we're not paying enough attention to, in particular for children's medical access to medical care, for clustering kids in practices with more vaccine refusers. I think threatening to kick kids out of school and then actually kicking kids out of school is a really, really bad thing, even from the point of view of health perspective. Right? The lifelong health consequences of not having access to formal education are horrific and probably swamp the marginally worse health outcomes associated with one additional unvaccinated kid being in school. I'm not going to make this argument too thoroughly today, but I present this as what the sort of alternatives are when we're talking about routine childhood vaccination. I also think the evidence shows that neither of these policies are as effective as their advocates think at promoting these goals. In particular, kids and families kicked out of pediatric practices do not vaccinate. They just cluster elsewhere or don't get care. And that even the state like California, that is heralded as a great success in kicking unvaccinated kids out of school, actually resulted in far fewer additional vaccinated kids than some people think. I won't go into depth on this, but I think there are good reasons to not want to fall back on these policies, even if, as maybe the panelists will push me on later, we have to, because maybe nudges are a problem. I also think they punish kids for things parents do. So just quickly on dismissing, this is really recent. As of 2005, right between a third and 40% of pediatricians were kicking these families out of practice. By 2015, the numbers are roughly the same, right? 26% are doing so. 26% of pediatricians are dismissing families who don't vaccinate. Same lead author, same survey in 2020, the number is now 46%. And this is pre-COVID. I've got to imagine, given the way that clinicians and public health officials I've talked to have been kind of worn down and beat down and maybe become less patient and tolerant of vaccine refusers, that these numbers are going to go up. I would love to see them run this survey again. Nearly half kicking people out of practice. And the AAP has been on this. 2005, the American Academy of Pediatrics said you shouldn't do it. 2013 said you should try not to do it. In 2016, they said it's acceptable for you to do it. There's been dramatic change, even just among elite medical folks, on the treatment of vaccine refusers. The culture, especially public health-oriented culture, has turned very quickly on these people. Is it unethical? I've argued it's unethical to kick these people out. It's bad for kids. It's bad for other people, because what happens is you're clustering unvaccinated kids in other practices. I think it is unfair to your fellow providers, because you are transferring on to other providers the burden of caring for both children and families that are especially burdensome. So I think if we could, we should be trying to retreat back from a practice that's now almost half of pediatricians kicking these people out of their practices. How about eliminating non-medical exemptions? This has been, for the major physicians organizations, one of their top lobbying priorities. We've seen success on this count in California, in Maine, in New York, and Connecticut. There's some other states with similar bills. Other countries are moving in similar ways. Huge ethical downsides. Some parents are going to pull their kids out of school. And so for some families, homeschooling is a good option. But for other families for whom it's forced upon them, it's a bad option for kids. Especially because these are exactly the kinds of vulnerable kids, often, that you want more state supervision of, not less. It's bad for access to education, to care. It's bad for parents, in particular mothers' participation in the formal workforce, which has all kinds of bad downstream consequences over generations. We also know that many schools, in particular private schools, will not enforce these, because both private schools are dependent on tuition and public schools are dependent on attendance-related reimbursement from the state for each child that's there. So there's amazing incentives not to kick these kids out. So these policies actually don't seem to kick kids out. There's some increase in vaccination rates, but actually they're not nearly as high as people have thought. And I'll argue, and happy to talk about this is one of the theses of my book, these kinds of efforts politicize vaccine policies that have been largely bipartisan for the past 50 or 60 years, in a way that I think there's a direct line from politicized conflict about school vaccine mandates to politicized conflict about COVID-19 mitigation measures and vaccine mandates. So, okay, here's the stuff I want to avoid. What are the other options? What could we do to not kick kids out of pediatricians' offices, to not kick kids out of school, and then in the context of COVID-19, right, to not be firing people or shutting down institutions or otherwise stigmatizing folks? There's not a lot, apparently. This is just a quick example. This is a famous paper. If you try and scare people, it tends to be counterproductive. If you show them scary pictures of kids suffering from vaccine-preventable diseases, it makes them more worried about vaccines. Because you've associated in their mind fear with vaccines, not fear with the disease that then turns into positive feeling about the vaccines. Our minds are weird, as my colleagues will surely confirm. What if you train physicians in being super expert about motivational interviewing techniques, like all the best ways to solicit values from patients, and we're going to do shared decision-making with families? No, it doesn't work. Basically no benefit, but intense amounts of resources going to it. What about nudges? That's the goal for today. So I've used, what, almost all my time already, just getting going. What is my cutoff time? I didn't start a clock.
We'll see. You got at least 10.
I got at least 10. So what about nudges, right? So it's more than it's more than like education. It's more than what are we going to do? So from the early decades or early years of the 2000s, a lot of people have been excited in public policy about manipulating people's decision-making to get them to make decisions that are good for them in the community without compelling them, without using force, without violating liberty, and often without people even knowing it's being done to them. So the fact is, right, our decisions are often sensitive to environmental factors or non-rational elements of the decision-making space. So sometimes our decisions are sensitive to rational elements, right? If I say this intervention has a 99% success rate and I respond to that, okay, fine. But actually, depending, for example, on how you frame that information, you can change the decision. If you tell me it has a 1% mortality rate, I'm much less likely to accept it than if it's a 99%. The same is, and it doesn't matter how educated you are. It's a famous study of Harvard physicians that found that framing bias is actually amazingly prevalent. It often results in substantial differences in decision-making, just how you present factual information. And of course, the order in which you present information or how you frame it is not irrational. It's not information per se, right? It instead manipulates features of our decision-making. And so look, if you know this stuff, if your social scientists have done their research and shown us where our biases are and what kind of heuristics we're using, then you can manipulate people's decision-making. You can use non-rational elements, right, to get them to make decisions you want without them having, one, knowing you're doing it, and two, without you having to act against their will or force them. So great, right, if we're concerned about liberty. And that's a lot of people are very excited about this for a while. Lots of different kinds of nudges. In fact, I hesitate to even talk about this with the experts here on my panel. And so I'll just say, you can do nudges in lots of ways, and we'll talk about that later, because I want to get to timing on some of this. But the short bit is, which I want to say for a few minutes, is nudges can be very effective. Some nudges in some contexts can be very effective. This is just a silly example. The silly example everyone goes to is the Amsterdam airport had a huge problem with men who couldn't control themselves at the urinal, and they painted these bugs on the urinal, and they basically made their urine puddle problem go away, right? Because they didn't have signs or cops there telling men how to urinate, but they instead put the little thing on it, and sort of people were manipulated into controlling it. It's a stupid, silly example, but you can make people change their minds, and that is a very non-consequential decision. But here's another example. In Congress right now, they're debating the Secure Act 2.0, which, if you're paying attention, it will make it a requirement that employers automatically enroll you in retirement savings plans. You still have the opportunity to opt out, but that when you join your company, they will, by law, have to have you begin. And why? Because it's a substantially higher percentage of people will stay with a plan they've originally been in and not quit it, than will opt into it if they have to choose, right, from the beginning. Huge literature on this. So this is another example, right, works really well. Here's the big one for vaccination. So the famous paper from Doug Oakland from 2013 shows that one way to think about it is, if you want parents to be vaccine hesitant, do informed consent with them. Tell them, hey, your kids are up for vaccines today. Here's the information. Let's talk about your values and your concerns. Do you have any questions? Let's see if this works best for you and your family at this point in time for your child. If you want your kid, if you want this family to be vaccine hesitant, that's the number one thing you should do. In particular, if you want them to get vaccinated, though, you should use a different communication style, which he calls a presumptive communication style, which makes vaccination the clear default. So you say to them instead, we're going to do these shots today, right? You really need these shots. You start swabbing injection sites and getting syringes ready, and you ask if it's okay, right? And often in pediatricians' offices, you will consent to the whole vaccine schedule, like at previous office visits. So the paperwork consent is already done, right? It's a sort of nurse and physician, right? We're doing, at your 4-month, your however-month visit. And what he found is you get 1/3 of the vaccine refusal if you use the presumptive communication strategy. If you present vaccination as a default that people are allowed to opt out of, but that you move forward until they say no, you can dramatically cut the amount of vaccine hesitancy and refusal you've got in the clinic, at least in a discrete one-off intervention. Funny enough, if you poll these parents, they will tell you they're much less satisfied with that clinical encounter in which they've been subject to a nudge. So they're sort of, how does this scale? Right? What happens if you keep doing this over and over again? These are questions I think on which the social science is less optimistic. Notably, in 2016, the American Academy of Pediatrics pointed to this nudge, this presumptive communication style, this default nudge, as the only evidence-backed discrete technique for increasing uptake of vaccination in clinic. And I gotta tell you, my first-year medical students get taught this in their sort of clinical communication, the first semester clinical communication class. They get taught, do default communication with patients. COVID-19 nudges. In the early months of COVID-19, there was a lot of optimism, a bunch of social scientists sort of bragging on their tools and trying to get people to pick them up. Were they effective? Maybe some of them, maybe a little bit, maybe in some contexts. It's not clear how much they scaled. Even when they were effective, they often came with like very small marginal increases. So offering people this, I think this was a study done overseas, if you offer people $25 to complete their vaccination appointment, you could increase vaccination rates by 4%. Another study showed if you used a particular kind of language in your text announcements from the pharmacy, in particular if you said things like, there are vaccines waiting here for you. If you used a kind of, and it's wild, like there was no different factual information contained in the text messages, but if you use those that had a certain kind of waiting here for you, apparently grabs people, or at least grabs 3.6% more people to show up and get the vaccine. Now you may say that's nothing, but when it comes to vaccination, the difference between 80% and 85% can often be the whole world. And so this is something, it's maybe not as impressive as we want, and as maybe my colleagues will push on me, maybe in the context of politicized conflict about COVID-19 vaccine, we are not going to have as many fence sitters who can be easily nudged. But I'm happy to talk about that. I want to talk briefly about the ethics thing and then have some discussion. Nudges are beneficent from the point of view of clinical ethics. Right? Nudges help people. They are paternalistic. In fact, their advocates call them instances of libertarian paternalism. Libertarian not as a political philosophy, but because it preserves liberty. They are liberty-preserving acts of paternalism. But a lot of people thought they undermine autonomy, at least some nudges in some contexts seem to, because they may induce bad reasoning, they may bypass reasoning, they may play on and sort of encourage people to sort of engage automatic reasoning processes or to otherwise engage in biased decision-making. And that might be okay. I'm actually willing to be persuaded in many contexts it's okay. It does seem like that undermines autonomy, at least on some robust Kantian conceptions of what autonomous judgment requires. But if you think autonomous judgment means making decisions for reasons that you yourself endorse, and you are being manipulated through non-rational means to make a decision you wouldn't otherwise make, I don't think then that's an autonomous judgment. So, and people have been raising this concern, there's a whole literature on should we be concerned about clinical nudges, and some people think yes, some people think no. What's really striking, though, is that people in the public ethics literature don't seem concerned about nudges. And one reason I think that there's very little in the public health ethics literature about nudges is autonomy is just not a chief value. Right? We care about liberty. We want to avoid violating liberty when we can. And we care about overall public health outcomes, but autonomy, not so much. We're happy to manipulate people if it gets them to wash their hands. Right? That's great. And so I think one thing that's going on in conflicts about ethics conflicts about nudges, but also ethics conflicts about vaccine mandates and other public health mitigations is we've got two different kinds of moral vocabularies that place different emphasis on autonomous individual decision-making that are leading us to some problems. And so context is central here. I think most people are very happy with nudges in public health contexts. I think when people worry, it's about in clinic. Well, okay, what about vaccination? What is it? Is vaccination primarily a personal medical intervention? Is it an instrument of public health? Is it both? And if both, what does that mean? And then here's some quick suggestions of how to move forward in this sort of ethical imagination of what vaccination is. Should we think of it more as a public health intervention? That is to say, should we think of it as something like paying taxes, right, or otherwise making a contribution to public projects? I think we're going to run into huge problems. First off, all of our messaging in this country about vaccination emphasizes personal benefits, costs, and risks. The vaccine information statements you get in clinic talk almost only about that. The way in which we sort of try and promote vaccines is similarly individualistic, which of course maps the sort of structure of the US healthcare system, which emphasizes individual benefits and individual responsibilities. And so the idea that you could transform vaccination into a sort of public health measure backed by a solidaristic moral commitment to the good of the community in the context of America's existing healthcare institutions, I think is unrealistic and would require something transformational. I was really struck, this was a tweet from the CDC when it was trying to get people vaccinated, and it sort of played into the perversities of our current healthcare system. You should get vaccinated because hospital stays can be expensive. Help protect yourself from being hospitalized because you're going to go broke. You should get vaccinated because it is so individually bad for you because our healthcare system is so broken, you're going to go bankrupt. In fact, it's actually true. I don't know if I took the slide. Oh, it was here. Yeah, a quarter of the people who got vaccinated for COVID are now bankrupt. Here's another way around, and maybe a more sympathetic way. Maybe informed consent's not that important. or maybe autonomy, in particular autonomous judgment, is not that central to clinical ethics. Maybe we don't want physicians coercing patients, but maybe a bit more paternalism, manipulation is fine in clinic. I've got some questions about that, but I think there is a robust tradition of being skeptical about the value of informed consent. And one way to go on reconciling this question is to just worry a lot less about autonomous judgment in the context of clinical medicine. But will the public tolerate that? Mark Largent, who's at Michigan State and had a vaccine book, he says, yeah, we just need to sort of balance public health ethics against clinical ethics. And we'll just figure it out. Sure, Americans care about their privacy and their autonomy, but they'll need to know that then you give some of that up for the public good. And I just think that's not a realistic picture of who Americans are. I'd love to see the social science on this. Dawson and Wiley say, look, if you study people, they actually think of health as largely an individual matter rather than a social responsibility. And so, be it nudges or be it vaccine mandates, I think you're going to run up against the ethics of the clinic as a sort of argument against those kinds of policies, and that you're not going to be able to make much use of the ethics of public health in trying to justify those to the people we have in America today. So thank you so much. I know I went over time. I hope I gave you something to talk about.
Well, thank you again for the privilege of being on this panel today, and for the kind welcome. Again, my name is Miriam Shalkida. I serve as an assistant faculty member at the College of Pharmacy, but it's a shared role. So I also work at the Ohio Pharmacists Association, where I've had the unique privilege of working with the state government on the vaccine rollout. So this has been my bread and butter for the last 2 years. And to say that it has had its ups and downs and heartbreaks and heartmakes is probably no truer statement that I can make today of the journey that we've had so far within the state of Ohio. So as I was looking through Mark's slides last night, I was thinking through what else I could bring to the commentary that would add maybe an Ohio flavor to what we've talked about today. So within Ohio, let's start with some of the nudges. Let's get there. What were some of the things that the government just decided to do, whether it was at a state level for everybody who resided in Ohio, or if it was a specific patient population? So let's talk about the lottery. Governor DeWine did a Vaccination program, and I was in the meeting that happened the week after that was announced, and we saw a spike. We did. We saw a spike in the vaccine uptake, but that spike was not sustainable. So it lasted while the duration of that Vaccination program was around, and then it went away. There was another, it wasn't called Vaccination, I think it was called Back to School Initiative, where the students were offered scholarships, and that again led to a very minimal but a definite bump in the vaccine uptake in Ohio. So to say that it had mixed reviews is correct, but in that moment in time, when our governor was looking and challenging many of us on those calls to get those numbers up, that was the solution that was found to work. In the Medicaid space, so let's talk about our patients who are maybe economically more vulnerable than others. What did our government do? Well, the Ohio Department of Medicaid and our managed care plans came up with an idea to provide $100 gift cards. And for some of my pharmacies that I talked with, it was physical gift cards that they handed out. And very popular, because you come into your pharmacy, you get your shot, you walk away with $100. And so there was a pharmacy up north, I think in the northeast part of our state, that called the Pharmacy Association up the week after and said, this is going to be nuts here. We're going to have folks breaking down the door for that $100 gift card. And he ended up vaccinating over 300 patients that month. So for that patient population in that particular county, that pharmacist actually led in the vaccine rates for that month because of this initiative. So that nudge worked for this particular pharmacist. I'm going to put on my public health hat and talk about 2 more nudges that opened up the door to other maybe social determinants of health that we weren't aware of. A pharmacist in Linden here in Columbus realized that her patients were aware of the vaccine but didn't know where to find them. So she went back to her managed care organization and said, the one that had the largest spread of populations, I forget if it was Buckeye or CareSource, went to them and said, you know those hotel door hangers that we have, could you make those into vaccine information placards with my pharmacy information at the bottom? And she just, threw the idea out there and then forgot about it, only to come to know 2 weeks later that it had worked because patients were walking through the door holding these door hangers and saying, I'd like to be vaccinated. And so they realized that it may not have been the patient's lack of want to get the vaccine, but just a lack of awareness of where to go. The bus system is really the only way most folks use transportation there. And for the ones who did walk in with those door hangers, it was because they could walk there. And they realized, okay, trio pharmacies where I can get my shot. Secondly, our managed care organizations had a meeting with us and said, we are aware that our patients may not have access to transport, especially in some of the areas where there is no public transport. What do we do? Then they came up with free Uber or Lyft rides. And so now, we're looking at a time when I should have brought graphs to share with all of you today, but the slide of where we are on the vaccine front has kind of plateaued, but what we've taken away from those nudges has been huge. So as part of the narrative for today's commentary, I wanted to add the fact that some of these nudges open our eyes to other disparities that we're facing in Ohio that we're going to take with us way beyond this pandemic. Issues of transportation, issues of how do we get our economically disadvantaged patients to a pharmacy to receive not only the COVID-19 vaccine, but the flu vaccine, the pneumonia vaccine, maybe their kids can get vaccinated. The laws that have allowed pharmacists to vaccinate 3-year-olds, my hope is that it stays forever so that my pharmacist can continue to vaccinate the 3-year-olds and above. Because there's such a crucial community face that they can speak to some of the hesitancy we're seeing today. So those are the commentary on nudges. Now, of course, my colleagues here may not have 100% agreement with me on this front, but nudges I think are helpful. They're seasonal though. I don't think that if we had a lottery system every single month of this year, that we would see changes in numbers. Because the comment that was made at a recent meeting was, what else do we throw at them? I mean, we did a Vaccination program, we offered them $1 million. Like, what else can we do? That's a lot of money. So maybe it's not money. Okay, what about, an incentive to get your kids a fun, they just did one over March Madness period to have a fun gift or something sent to the kid, which was themed around March Madness. Great, didn't change our numbers as much. So it's a complex way of dealing with hesitancy. And here's my closing comment, and I'm so glad Mark you mentioned the whole thing about how society is built. Because I think what us public health practitioners tried to do was we tried to say this is a social responsibility. And as a community, we need to protect each other. And as I'm saying this, I'm looking at an audience back then, look at patients, look at pharmacists who just did not compute. And we walked back and we said, what did we say? What isn't healthcare a social responsibility? Not in the United States of America. Why? Because I think our culture is built up on the thought that healthcare is your own responsibility, it's yours to keep, and you decide what you want to do with your body, your choice. So the question we need to be asking is, today, moving forward, what kind of narrative is public health? Are our ethicist friends telling each other, telling our patients and our communities about healthcare? Is this a time when we have the world's attention on us? Is this the time to change that narrative or to start building up some commentary around it? Because I think a lot of our country thinks that the pandemic is over, but let's talk to people in India who have yet to see a vaccine, because the vaccine can't be stored in their ice cooler in the most remotest part of that country. Let's talk about that. So COVID has never gone away from that community. Let's talk about the fact that we're seeing so many variations come through that it becomes just the news of the day. Or I've learned the Greek alphabet through the variations that come through. So that's the unfortunate side that we're probably going to carry with us as public health practitioners, or even in other worlds, whether it's in the healthcare, the ethics, or in the public health space. We're going to be dealing with this forever. Not forever, I shouldn't be that pessimistic. We're going to deal with this for the immediate future and hopefully not past that. But what are the lessons that we're learning here? Is it that nudges are seasonal? Is it that our patients maybe have to be given a message that their healthcare, although it might be their own, is part of a network of communities that go way past Columbus, Ohio, go way past the United States. Actually, it's a global thing. So I will step off that soapbox. Thank you.
I feel like it's on. Okay. So I think part of the message is that our job will never be done. And I think in a conversation about public health ethics versus clinical ethics, we have to think about, what I think about, is what is the level of the intervention. Public health interventions tend to be at the level of the population. They're systemic, they're structural, these sorts of things that sort of don't boil down necessarily to the individual. We hope it influences an individual's behavior. When you think about the most successful public health campaigns in reducing negative behaviors, I think of smoking. You know, we saw like systematic increases in taxes on smoking over the 90s and into the 2000s, and then we began to see bans on smoking in public places, first in the state of California, then in many municipalities across the world, or at least across the country. And it had those two things had the single biggest impact on on smoking behavior than any of the other individual level interventions that we had been doing up until that point. So these things can be profoundly impactful. But smoking behavior is a negative health behavior, right? There's negative health behaviors, there's positive health behaviors. Smoking is, I think, fairly objectively a negative health behavior, given what it does to people's health in the long run. A very successful positive health behavior type public health campaign came with Back to Sleep in the 80s, and again, like pulling it into the 90s. SIDS was a huge problem for babies born in the 60s and the 70s, and as soon as you learned that babies sleeping on their backs made a huge difference in the rate of SIDS, that message, getting that out to moms, made a huge impact. The rate of SIDS deaths dropped by something like 70 or 80%. Because as that message began to get out into the population. So it's a nice example of probably coercion, right? But it was a simple message that we began to give to moms to say, this is how you keep your baby safe. Let them sleep on their back, don't put them on their belly. If I'm a mom of 3, it's real hard to adhere to that because any baby would rather sleep on their belly than on their back, but you do it until they can flip, until they have the strength to breathe on their own. Should something happen in the middle of the night. But these are, I don't think of that as coercion. It's a nudge, right? But to me, it's a pragmatic way to convey a health-promoting information to a population. But at the level of the individual, we're talking about something quite different. So I've had employees who have struggled with whether or not they wanted to be vaccinated in the face of the mandate that we have here in Iowa State. I've had patients who have struggled. And it is a conversation that at the level of the individual is a little bit easier to have than I think you might think. Many of the arguments people have and have shared are fairly sympathetic at the one-on-one. And most people do not wish to harm others, but there is much fear that came with this. And vaccine plus illness, those messages do make people more afraid. People have been afraid, and mothers, and I've looked at some of the data recently that have to do with sort of our 0 to 5 population who cannot yet be vaccinated, where the intentions are within that population. People are split because they are afraid that they don't have enough information about what will happen in the long run to their children. Now, these are not problems that we saw with polio vaccines. It's not really with polio. When the vaccine was rolled out, something, I think it's 40,000 doses were delivered to people that had live virus in them. And I'm sure it made its way into the papers and things like that in the 50s when it was occurring, but people still trusted the system, as it were, to get vaccinated for polio. When the chickenpox vaccine was introduced in the 90s, there was some issue for parents that is chickenpox really so bad? But when the information was fleshed out and when it became part of the standard panel, uptake increased considerably. And so, to me, it's conveyance of accurate information to individuals. But these techniques that Mark has gone through, sort of shaming people, guilting people, all of these messages, they don't work at the public health level. And so that conversation between the provider and the patient is powerful. Things like appointment reminders do increase the likelihood. In my own clinics, we send these things via MyChart. If the patient can click a button and make an appointment with their provider via MyChart, they are far more likely to do so. And is that coercion? I don't think so. I think that is a convenience. So as I think about these problems, I think about the busy individual who needs help and assistance. And that piece of informed consent, once they get into the office, we explain to them what is going to happen. They can say yes or no, but I think they do sign all the time. And I am less concerned, I think, than many would think about this opt-out idea. Because I do think we have busy lives and it makes people's lives easier to sort of increase that convenience. So from where I stand, whatever we can do to support communities and the people within them to do the things that we know should be good for them, I think that those are all good things. And I hope that's not a terribly spicy point of view. It feels okay to me to say it out loud, so I hope that that stays true.
Thank you all for your thoughts on the subject. To kind of get the discussion going, I have a couple of questions that I want to ask. I want to start with kind of a couple of slides into Mark's presentation. He had this list of all these different types of nudges. And one of the things that struck me about seeing that list is that I think these nudges are not all morally equal, right? There strikes me as something very different from changing an opt-out policy to an opt-in policy. Compared to manipulating the way information is presented to exploit a framing effect. Those seem to me to be very different kinds of nudges and might warrant different moral assessment. And of course, those are different than the outright financial incentives of just, the Vaccination program or paying people a set amount of money to get vaccinated. So one of my questions is just, how do you all evaluate which kinds of nudges are permissible to use and which ones aren't? Like what, on that list of all those different types of nudges, like what's okay to use and what should be off limits? What goes too far in seeming manipulative, right, such that it would be objectionable, whereas other nudges are not as autonomy infringing or not as coercive or manipulative and so are permissible. So,
a quick point. Yeah, that's a good question. One distinction that gets made in the literature is between nudges that some people claim are autonomy promoting nudges and nudges that are autonomy bypassing. So as Kristen and Miriam both said, when people are fearful and making decisions, they're not making decisions rationally. They're not making decisions in a way that consistent with their own values and deeply held beliefs. And so in that context, if you're able to help them sort of bypass the influence of fear upon their decision making, right, by playing with affect in some ways, then maybe you're actually encouraging, right, more autonomous judgment. So those, I think, might be commendable from the point of view of clinical evidence. I would worry more about autonomy bypassing nudges when people are now making decisions for reasons that are not their own, and without even knowing that they're making decisions for reasons that aren't their own. Here's another, so that's a sort of two-part distinction. I think the other distinction would be, and this is kind of irony of nudges, the more effective nudges are, the more I worry about them. Because the more effective they are, it indicates the greater degree to which the nudge is doing the work, right, rather than the person's own values and beliefs. And so it's the more autonomy violating, right, you are. So for example, on the financial incentives, $25 does nothing for, people who have plenty of money. It does a lot more for people who have nothing. And in fact, this has been a problem with global vaccination efforts, right, for a long time, where they're often handing out food to deeply impoverished and maybe starving people. Here's some bags of flour and rice and corn if you get vaccinated. That is manipulative to the point of being coercive, right? Death and starvation is a real possibility unless you get the vaccine. That, right, is much more ethically troubling, I think. And so how effective is the nudge? I actually think I'm worrying more about it the more effective it is. And then, is it autonomy promoting or is it autonomy bypassing? And I think you're entirely right. It's not just different kinds of nudges to assess differently, but it's different nudges in different contexts. So that'd be my general statement.
And I would say too, it depends where the nudge lives contextually, because as you sort of alluded to, as a mom who goes to the pediatrician's office, when I signed up my children to join this, when we decided this was our practice, they were very clear. We follow the vaccination schedule that we have from Academy of Pediatrics. It is always subject to change. If you have concerns about this, you may talk with your provider. So when I walk through the door with a 12-month-old and they say, "You've got 5 shots scheduled today, would you also like the flu?" I'm like, yes, I am fully on board with that because I have been paying attention from the beginning. And so I think we have to be doing things right from the beginning as we think about nudges, if that makes sense.
I think one commentary that has been a consistent part of our talks with the state government has been not taking advantage of either the most vulnerable or the ones with the most power, both ends of the spectrum. So how do we do that in a way that either promotes equity or does not infringe on their ability to make a decision outside of their economic disadvantage or their ability to make a clinical decision? And again, the other part of this is we use the word making clinical decision making to people who have never come near a STEM degree. And so how do you educate a patient fairly without assuming that, okay, so first I have to talk to them about immunology, then virology, then how a vaccine is developed. I mean, that was some of the discussion we had at the initial stages, and then we realized, okay, we've lost the plot here. We're not called to, from an area of fairness, we're not called to get our patients to be us, be those STEM experts. What we are called to is give them the actual opportunity to make that decision, and potentially with a nudge that is not going to push them one way or the other because of either financial need or convenience or the promise of winning a large grand future in the terms of a scholarship or money itself.
See, I thought with Vaccination, they should have given $100,000 award so that more people would get that.
I actually told that to the governors.
Because that is life-changing money for any human.
Can make
right?
a difference in your life.
Yes, I thought they should give lots of small awards, but no one asked me.
No, it was $1 million.
Was there, are you taking questions from the audience? Or
Yeah, we'll take questions from the audience. I have one.
Trevor's not giving it up yet.
No, I got one. Sorry, I got one more. I gotta ask you a question about informed consent, which you kind of raised some skepticism about. I don't know, you were kind of wishy-washy on in the presentation on like the overall stance, but seemed kind of not a fan of informed consent.
I think we're all probably fans of it, but being realistic about how fully informed patients are when they engage.
I mean, this is exactly Marion's comment, that especially if you're trying to get informed consent for a vaccine that's under emergency approval, how do you explain to people the sort of research ethics guidelines and the sort of how to weigh different kinds of evidence and how to weigh sort of type 1 versus type 2 errors in light of different values people have? I mean, inductive risk is hard enough for philosophers of science, never mind trying to explain to patients these problems. So I think, so first off, I think that I join with lots of other people who are skeptical about informed consent as a realizable ideal. And so instead, I think that most of the time what's going on in clinic is, of course, we want people to not be coerced and compelled, we want to respect choice, but that I want to choose physicians I think have my best interest, my family's best interest at heart, and are probably manipulating me in all kinds of ways towards decisions that I hope are the best ones, because that's actually what I want a physician to be. So I'm much happier with more paternalistic medicine. I mean, I have a whole revisionist story about the history of bioethics, for which liberty is the chief value rather than autonomy, but that's another talk entirely.
This actually speaks to what I wanted to ask about, because so I teach about informed consent in my pharmacoethics class, and one of the views that comes up is essentially about understanding informed consent not as literally just giving the patient all the possible options and being like medically neutral about what is appropriate for them. It's not crazy to think that informed consent can be compatible with making recommendations, maybe even strong recommendations, right, as a physician. And I wonder if the issue here is maybe that the bar for like what a patient has to know to make a decision is just being set too high, right?
I think the idealization of it is very high, but I think pragmatically what actually happens is quite low.
Well, and the formal requirements for informed consent are actually are quite minimal, right? It's you are making a voluntary decision, right, based on being informed, and that could be a quite low threshold, and you possess decision-making capacity, which is a whole contentious discussion, what is involved in decision-making capacity, but I think that can actually be a quite low threshold as well. So I don't think there's any Kantian conception of autonomous decision-making built into the formal process of informed consent, though clinical ethicists often talk like it is or should be, as a sort of idealized notion, and I think that's mistaken, but yeah, so I think actually informed consent is consistent with all kinds of manipulation.
And speaking of informed consent from a popular culture standpoint, how many times have we heard people say that they've done their research? And what does that define as? And when done, their research means going on their favorite Facebook group or Twitter following group or whatever it is, mom blogs, etc. What does that mean? And again, the bar there is varied. And there are people who genuinely enjoy the process of research and have been trained with that, and then there are others who are just Facebook fanatics, and that's different. So that has also informed some of that communication around how much does a patient know before they sign off on anything.
Well, and the idea that being more informed is going to lead to better
Just
decisions is
right.
naive. So studies have shown that vaccine refusers have more true beliefs about vaccines than vaccine acceptors do. They also have more false beliefs, but they know a lot more. They're trying really hard to be informed. They just have come to often some false beliefs and what I think are some bad choices.
That's a fascinating piece of information. Anyway, I don't want to think about that too hard. So, someone in the audience had a question.
I did.
You can.
That's okay.
Oh,
I'm loud.
all right.
I can hear you.
Sounds good.
Yeah.
People have no lives.
There's just us.
There's people have lives.
We'll repeat it.
Okay.
Professor Navin, when you were talking about the scenario with, I want to make sure I get the verbiage right. And I can't find it in my, presumptive communication styles. And then Professor Reignited, what you were describing about people not necessarily, an assumption of what you can explain to someone. And that feels to me very manipulative. To say, a mother who has a 6-month-old, she's exhausted, maybe she doesn't have a science background at all. Are there things like this, Professor Reignited, that you learned about from your time working with the state about what are more empowering nudges instead of the bypassing nudges that might be something like that?
So some of the more empowering nudges that we found is using the same types of nudges, but who's the one delivering it?
Interesting.
A community leader who's trusted. And in my scenario, I'm standing here very biased as a pharmacist, but a lot of them were pharmacists. But in some communities, it was their local pastor. It was a teacher who was at the heart of society. So in that sense, we learned very quickly that oftentimes the director for health would step aside on purpose and let the community folks get the PR first, get the social media squares that we could present to others first, so that when the news first came out, it was from the face that they knew and loved and trusted. And not to say that other people don't trust the head of the Department of Health. I trust that person. But that didn't matter. I was vaccinated. So for the communities where we do think there might have been higher vulnerabilities, we said, community leader, where are you on this? And if you do align with us, would you join hands with us? And that was probably the most effective measures we saw, at least from the pharmacy work stream. And there were other work streams that where it worked as well. The local health departments, they reached out to local teachers, and the teachers were the ones that held the town halls. And let me tell you, those were far less toxic than the ones led by usual public health practitioners. In other, let's talk about 10 years ago. Well, let's talk about the Ebola crisis. Public health practitioners were the ones passing information. This time, not the case. So that would be my answer.
And it's not novel necessarily to use sort of community partners to promote public health. There is a ton of work around cancer screening, for instance, that has happened, both research and practical work in terms of cancer screenings. How do we use faith communities, for instance, to help promote among underrepresented minorities? How do we promote these kinds of behaviors and trust? And people trust someone who is not a stranger, even if it's delivering the exact same message. And I don't know where that lives in terms of ethics, whether it's coercion or not, but it feels like a really good idea.
Well, so it might seem manipulative to put up a celebrity or recognized leader, and so why am I deciding? Well, not for my own reason, because they get safe and effective, but because my good affect about this person rubs off into some good affect about this intervention. You might think that's manipulative, and it might be in some context, but it depends on whether one of the person's deep convictions is to do whatever their community is doing, what their leaders speaking for the community are saying. So, for example, we had a measles outbreak in Southeast Michigan a couple of years ago that was brought to us from New York, and our public health leaders, with partnerships with the local Council of Orthodox Rabbis, were able to deliver 2,000 doses of MMR in a week in community health clinics. It's because Orthodox rabbis said, our understanding of Judaism and Jewish ethics requires you to give the sex. And so, okay, were they doing it because their leader said so, and the leader's positive affect rubbed off on it? Well, okay, maybe if that's the story, then maybe it's just manipulative, because it's bypassing reason, it's just an affect thing. But if they, as devout Orthodox Jews, wanted to do what their community says is right, and this is their community leader speaking all that's right, well then no, I think that's maybe an autonomy promoting.
It is how they learn that the behavior is consistent with their values.
Yeah.
And for some people, that is primary.
But a celebrity sort of advocacy is maybe
Cuts both ways.
is maybe more manipulative, right? Because it's just sort of a good affect rubbing off from one to the other.
So I've got 3 separate points. How about that? One, just a comment about the informed consent, and what I think is some of the problems with our current technique is it in fact is heavy on what the provider or the researcher does. That is, we are a deliverer of information. We don't require understanding. So there are some models that are being advocated that before you have an individual sign is you actually are assured the person understands the information. That's not our current model, either in research or in practice, right? So all the physician or the nurse has to do, or all I have to do as a researcher, is to read this thing so I can say I've done it. You can voluntarily sign, nobody's coercing you in some way that you won't go. But you may not have understood one word I've said, and nobody's going to raise an issue with it.
Just as an example, I always hear nurses and doctors sort of say, "We consented them."
Yes.
It's something I did to them.
That's
Right.
exactly. It's an other sort of thing. So that was just one point about it.
Yeah.
The other comment, I enjoyed the polio, and actually I would say I'm of the age that actually went through the polio, and there really wasn't any informed consent. We were lined up as elementary school children, and we were given a vaccine without any question. There was never any issue. So it's a contextual difference in where we are as a society relative to that. And think about trying to do that now in the school. And, there were 200 kids, and we walked through, and it's just a different way to think about the sort of public health sort of thing. The other point is about why public health ethics doesn't seem to be bothered by nudges. And it strikes me that oftentimes the public health nudges are nudges that are competitive in the sense that industry has a nudge on the other side. So, and nobody's raising an ethical issue when Philip Morris does a giveaway for cigarettes, or when some other health food supposedly actually is completely full of high sugar, etc. So I think public health views it, at least in the work that I've done, is that you're not doing it in a vacuum, right? You're not going in where people aren't being influenced by other nudges. So you're competing against other nudges. So that was just the sort of your point about they don't seem to be bothered. I think part of it is the idea is you're trying to nudge them maybe into a neutral spot so that you, in fact, can let their own decision-making sort of take over. I mean, I really liked your autonomy bypassing versus your autonomy promoting nudges. You think about the structure of cafeterias, which is part of the discussion of nudging, right? So you can structure cafeterias where the first thing you come to in the cafeteria is the salad, or the first thing I come to in the cafeteria is the desserts. And studies have been done on this. It shows if you put the salads first, you get more salads eaten. And I think the argument from the public health side is, again, it's systems thinking. How do you develop systems that make the healthy choice not always the first choice, but at least a possible choice. So those were just comments I had sort of, as you were thinking about those sort of public health ethics and
Well, there's a lot there, so maybe I'll just make one response and ask panelists, because I think there's something really meaty, which is, so my question to you and to others is, when we think about trying to build a society that thinks of public health, or thinks of health decisions more generally, in a solidaristic, community-oriented way, do we want to think about going back to a sort of lost golden age, or are we trying to rebuild something towards the future? And because I hear people invoke the polio pioneers, right? I mean, this is the biggest experiment on children like ever conducted.
Yeah.
I mean, and I ask, well, why was it done? And there's not a lot written about, there weren't a lot of sort of in-depth interviews of why parents' motivations, but I think there's good reason to think there was a lot more socialization towards conformity and towards obedience. We lived, especially in sort of white, suburban, middle-class life with both political parties who were not polarized. And so we had a sort of bipartisan conformity in the culture. We also were decades away from the bioethics revolution and ideas about informed consent. That doesn't hit until the 70s and the 80s, and not even really sort of taught to med students and operationalized in the 80s and 90s. It is a world marked by forms of conformity and obedience, right, that track white supremacy and like organized terrorism of non-white populations across this country. And I think the kind of pro-health behaviors you might see in something like the Polio Pioneers is caught up with that kind of culture of illiberalism and obedience and fear. I don't think we want to build that kind of world or go back to it.
It would be nice though if we had trust. I think it was also
good,
marked
yes.
by
So
trust.
this is actually my question. In what ways do we want to go back and recapture something we had? In what ways are we trying to build something new? I'd be really curious to hear what the panelists think about that.
I do think trust is an important piece. We see all this talk flying around of misinformation and mistrust of the system. And some of that trust was obviously misplaced when you think of some of the work that has been done historically in medicine. But I do think there was trust that the government and its extent, your CDC, your Department of Health and Human Services, that they would do right for the public. I think that we have continued to see, I mean, I remember, like, as a freshman in high school, very distinctly being sent home because I had not yet had my third MMR, I think it was what it was. They just read our names off and said, you all have to go home right now and get this, you have to draw titers or get your shot and get this taken care of. We all had to go home, and then we were very excited because we felt like we got 2 weeks off of school. But we all kind of walked out, and there were people that had to stay behind. But I mean, the first thing my parents did the next day was make an appointment with my pediatrician to get me back into algebra. And there was an assumption that this was coming down because it was the right thing. And I think we're seeing a different kind of idea right now where lots of things float around and are amplified in ways that are really problematic, whether it's on social media or in now the televised media, whatever it is. You see these things, something small magnified. When you think about the damage that was done in terms of vaccine uptake and hesitancy with the falsified data on the influence, the contribution to autism. When you think about what that has done and how long it has left, that paper has been retracted, the guy admitted he lied and made it up. I mean, all of those things have occurred, and the damage that still lives. I mean, I have very highly educated friends, one who has an autistic son, who feels like that might be still very smart woman, has seen everything 100% her. But those things linger, and the ghosts of them last a very long time. And so what we see now, I don't know that we yet have the tools to combat it well. I hope that we will.
I'm going to say one quick thing.
Yeah.
There's a paradox associated with trying to rebuild trust, right? Because the minute you say, I'm trying to rebuild trust, you're signaling to people that you're not or have not recently been trustworthy. And so you can have, no, it's a real problem. So the American Academy of Pediatrics and CDC called for the removal of the mercury derivatives in 1999 from the vaccines, even though they were not the kind of mercury that can hurt people, but they were the kind of mercury some people were worried were causing vaccine injury. And they thought that by doing that, they would increase people's trust in the vaccine. But actually what they signaled to people is that these vaccines used to be dangerous.
It actually was, yeah.
And so efforts to promote trustworthiness, there must be all scholarly literature on this, but they often are not successful in the straightforward way that you might think they would be.
The other piece that I wanted to add to that question of where we want to see the future go, yes, I agree. I'd like folks to continue to trust the scientific process, and it's unfortunately not where we are today anymore. The other piece that we didn't have in the polio or any sort of even 15 to 20 years ago is the power of social media. Chickenpox, there we go, yeah. Chickenpox and polio, social media. So anyone has a microphone, as long as you got Wi-Fi access and the ability to put on a profile somewhere on any sort of social media platform. So suddenly we have society listening to whatever little communication circle they so choose, and within that communication circle, I don't know if it's myself who's the topic expert or somebody who just decided to pick up on vaccines yesterday, or wants to, or has heard or read a particular book and has developed an opinion that's going to stay in that group. So I think the challenge that we have today is that society has moved, and I would just say it, we've become more narcissistic. And whether that's how many likes I have or what my opinion is versus your opinion. Now, and then of course, popular media, anyone who has to sell anything, including anything from politics to products, are on social media now and are part of that narrative, when in the past, if it was chickenpox, it was the director of health. If it was a vaccine, it was the person who developed the vaccine. Now it's the person who developed the vaccine, his teenage kid, the neighbor down the street, the neighbor's dog down the street also who has a profile who can talk about vaccines. What are we doing about that? We can't regulate that. So I know that I'm standing on one platform, there's other larger issues that could be addressed too, but I think part of the mistake of the mistrust that's happened recently is folks went on social media and said something, and then I have recorded evidence of a public health leader telling me that masks aren't required. So I have a video recording that I can repost and repost and repost over and over again if anyone questions me. So now I think, aside from the narrative that we're trying to put out in the research papers that we publish, in the other books that we publish, we also have to consider the social media aspect to say, what does it mean to be a trusted person on social media, and how do we work with individuals in that space to be truthful, and maybe to admit to some of these mistakes that we've made in saying, okay, masks weren't required, but they are now, but they won't be if you get vaccinated. Oh, psych, actually, no, you need a mask because Omicron's back. So there's just a lot that has gone into that space that nobody in the past has dealt with. And I think, I tell my students all the time, I say some of us need to be educated on what it means to navigate social media as healthcare practitioners, as scientific researchers, because we don't have enough people in that space telling the truth. Okay.
This is so great. There's a lot of great comments, and I have so many thoughts and questions, and it's really big questions about democracy and littler questions about what you come up in like informal consent context and things like that. But let me just say two things. One is, I'm not concerned about nudges in general, and one of the big reasons is that nudges, by definition, as I understand them, are supposed to be easily overcome. So when you start talking about certain kinds of things that look manipulative, in a couple of the examples, like for instance, poor people who are being given some kind of financial incentive, but otherwise they're going to starve. I'm not sure we're really talking about nudges in that case. Like,
right.
So I do think like if something becomes really manipulative in that way, then it's not really a nudge anymore the way they're talking about. Whereas putting the salad front and center, where it's easy to grab the dessert if you just want the dessert, that's a nudge. So I have to say, I mean, we can talk about cases, but in general, I think I find nudges as I believe they've been defined usually as like unproblematic from my perspective. But my question really is, I have another quick comment and then a question, fear. So the comment is that I think for me the big disappointment of this whole COVID era is the failure of sort of a basic level of social concern among people. And I think you've all sort of alluded to this. I think there were two moments during this time, one before the introduction of the vaccine, and sort of one after the introduction of the vaccine, where people were talking about flattening the curve. And there was this, it felt like, as a guy who teaches ethics classes, I was like, this is awesome. This is an education in social concern. Like, we're flattening the curve. It's not about you. It's because these hospitals are getting overrun. We're worried about vulnerable populations. Like, this is going to improve our whole society if we can all internalize the message about flattening the curve. In just whole segments of our society, that did not take root at all. And I just found that extremely disappointing. So then here's my question. for the people then who never got on board with that and continue to be entirely about themselves, doesn't fear work? And the reason I ask is, I listened to This American Life podcast where Frank Lutz, maybe you've heard of, the Republican pollster, got together a group of vaccine-hesitant people to hear like what kind of messaging might work on them, because Frank Lutz, was pro-vaccine. And he brought in a bunch of like prominent Republicans to talk to this group of mostly Republican vaccine-hesitant people. And they were just like not successful in convincing this focus group to get a vaccine when they were just giving them like scientific information and all that kind of stuff. But then in came Chris Christie, who had been COVID positive, got COVID at that White House event, if you remember. He was one of the people who got it at that White House event. And then he said, but you know who else got it? Not just me, like big Chris Christie, but the healthiest person in the whole White House, Hope Hicks, right? Who was like ran every day and everything like that. She also got it and had a very bad experience with COVID. And then he basically said to them, he said, yeah, he basically created a sense of uncertainty and risk. And he just was like, you just don't know who's going to get it, and it could be any of you. And then, like, it seemed like the way they tell the story is like, because after that, then people started saying, oh yeah, maybe I'll get the vaccine. This whole group that had not been convinced at all, maybe I'll get the vaccine. And so, like, I mean, I hate to go down this road of like, the game is all about who can scare people more. That sounds like a horrible society to live in, where we're all just trying to scare each other all the time. But doesn't fear work?
Fear and uncertainty are two different things,
Okay.
right? Fear is an emotional response. The modal sort of behavioral reaction to fear is not action. It's either freeze or say nope, like into sort of flight, right? But uncertainty is a very interesting idea and a different one, because those people might have walked into that moment certain that they didn't need it, because they weren't that super unhealthy guy, like, I don't need this, I will be fine. Like, look at the people who are dying are older adults or people with all these health conditions that I don't have. What he gave them is uncertainty in that conviction, because he said, this exemplar is very healthy, she is young and vital and vibrant, she also had a very hard time. So it might not be fear so much as picking away at that belief that I don't need this thing, because I am different than all these people that are struggling. Does that make sense?
Yeah, is there literature on that? How can we weaponize that to
Weaponize
like
uncertainty.
to encourage people to like reconsider what they know, to reconsider the evidence, to rethink things. You know, I don't mean to like manipulate people.
No.
I just mean to like get them into the state where they're like willing to reconsider what they believe.
Like, people are moved by personal experiences and by exemplars that they can relate to, right? Like, those are the kinds of things that can move the needle on an individual. And when you want to change the thinking of an individual, it has to feel true. Like, if you're providing contrary evidence to a strongly held belief, you will not peck away at that belief unless it feels true to the individual. So, an example, I do a lot of cognitive behavioral therapy for people who are depressed, for people who are anxious. People who are depressed, like, I am terrible, might be sort of a thing they have about themselves. I can't come at them or even have them generate their own thought of like, I am great, because they don't believe it. I need to find successive approximations that push them toward an idea, or I'm a bad mom. When we find evidence, when we're gathering evidence, it has to feel true for it to really move the individual. And I think that the use of those kinds of exemplars, like who can I relate to, I think that's why celebrities actually can influence behavior. They feel
Why do
related.
you think it was that when Donald Trump actually did say, like I'm vaccinated, you should get the vaccine too, why did that fail?
What did he say before that? I think he had a history of saying things that were incompatible with that notion, quite publicly. I think that there was a lot out there on social media that suggested he didn't really get it because like he didn't really see the needle go in, and I think that there was doubt expressed and amplified on social media. That is my read of what had happened there. He also might not feel relatable to every individual, even amongst those who had voted for him. He remains an extremely wealthy white man in a place of privilege.
mean, I might just say briefly that I bet it's easier to cultivate uncertainty when the set of beliefs that you are trying to undermine is relatively small or on weak foundations. But I think one thing that social media does for people is help to reinforce and cultivate an entire alternate set of facts that as time goes on, and I think we saw this, right? There's a big, so that the polarization, so the difference by political party in vaccination rates was not present in first half of 2021. It's a second half of 2021 issue. And I think that's not because there wasn't anti-vaccine sentiment being said by Republicans in 2020, at the end of 2020 and early 2021. I think it took a long time for the sort of edifice of anti-vaccination to sort of establish itself. And then once it was established, I think there's no getting at it in any direct way. I mean, it's very speculative, but I think it's striking that there's not the partisan divide in the first half of 2021 that there is in the second half of 2020 vaccination.
It would be great if we could weaponize it, but.
It was the wrong bad choice of words.
We're just going to drop Socrates into some rooms.
I mean, you just want so badly for people to believe things that are true, but that's not really how we work. We believe things that we believe and encounter our experiences day to day. And so working, like Mark is saying, discrete, narrow beliefs are a lot easier to believe than big ones. And if the behavior that we're seeing is governed by, like, this government is wrong, it is not mine, it does not belong to me, those are harder than, like, this vaccine might be good for me.
I mean, it's sort of poignant in some ways, right? It's web of belief. Like how central is this anti-vaccine, right, to this person's structure of beliefs, right?
Yes.
And I think for some Republicans, unfortunately, the anti-vaccine stuff has become increasingly central, and it's a huge problem. And I mean, we were talking before. I'm really worried about the spillover to the routine childhood vaccination program based on political polarization. And if there's every reason to think that's going to happen, given how central anti-vaccinations become for some Republicans.
Here's your follow-up.
Well, just one other point I'm curious what you think about is, I mean, I feel like we should be talking about trust. I do think, like, you sort of wonder whether, like, the idea of democracy and expertise are just sort of like opposed ideas. I don't think they need to be. I think doesn't matter. This philosopher I'm interested in sort of thought you can't really have a functioning democracy where there isn't some idea of deference at work, willingness to let people make, because we do it all the time, right? Like if we were going out to dinner tonight, right, we would defer to the person who knows the Columbus restaurants best, right? Like we're constantly deferring to each other. But somehow you get into a political context and we're in a democracy and it's one person, one vote. Somehow deference feels like it's at odds with like some core idea of democracy or something. We should just, but I guess my question is, or my comment, in which I think, wonder if you agree, is that I feel like a lot of scientists that I talk to are not that good about talking about why you should trust the science, because a little bit as an outsider who's thought a little bit about the scientific process and method, it's not about trusting individual scientists. It's about trusting a community of inquiry where the evidence is public and people are incentivized to check each other's work. And if you could just deliver that message about that it's a community of inquiry, and what you're doing is trusting a process, a community that's built a certain way with certain kinds of incentives and transparency commitments, then that undermines a lot of the criticism where they say, well, but you could be biased. You could be biased. It's true, each and every one of us is biased. But the community as a whole has a kind of trustworthiness because of the incentives, and you get my point. I feel like scientists aren't that good about communicating that message about why you should trust the science, even if it might change over time.
Can I say two quick things?
Yes.
So I don't think there's any shortage of deference to experts in contemporary American society. What there is deference to sort of meta-experts, right? So like everyone is deferring. So it's not as if your anti-vaccine people are all radical individualists about their epistemologies, right? They're deferring to experts. They're just picking the wrong experts. And so the question is about meta-experts. Like we need to be deferring to the people to tell us who the experts are, and that's connected to the question of the scientific community. And I think one of the big problems is that the sort of practices of adversariality and sort of mutual accountability that characterize the scientific community are not often seen as virtues by some anti-vaccine people, who actually what they want is a more therapeutic community of inquirers who are sort of mutually supporting each other's narratives, for example, about vaccine injuries and vaccine risks, right? So the sort of online communities of mamas, right?
Very validating.
Yeah, they want to be validated in their experiences, and they see themselves as communities of inquiry, but it's inquiry through a sort of therapeutic lens of mutual validation, right? And so I'm not sure they actually recognize as a virtue the kind of adversariality of the scientific community. They don't want to be held accountable, for example, in that way.
And it's, you have to strike a balance, sort of trust in the collective, like you wish for something, as you say, like in a democracy, in any society, right? Like there needs to be some trust in a collective. Hopefully that collective is governed by principles of beneficence, non-malfeasance, all of these things. But I do think at the level of the individual, it's easier to trust a person. Because it has a face, it has a name, it has a voice. Whereas collectives, sometimes I think don't feel that way to individuals. And the person who becomes the spokesperson of the collective, we're not very good, right? Each of us individually, none of us are that great at talking about it. And so if you find someone that is more interpersonally compelling to you as an individual and speaks to and validates your fears, concerns, and needs, your behavior is likely to be more motivated by that individual than someone. I mean, and I think there was also a lot more deference to expert early. Like people had a tolerance for it at the beginning that they lost because it has just gone under.
I'm not sure that's true. I think they picked other experts.
Maybe.
They're following the frontline doctors and their alternative treatment regimes. They're following these other, Joe Rogans and these other people.
I mean, I don't think we can call him an expert.
Well, you're right, because you're a meta-expert, and you know who some of the experts are.
So we have a couple minutes left, and I did want to close on one question that I have. All of you kind of alluded to this in various ways in remarks that you've said. But it's basically the question of, like, I read off at the beginning of my introductory remarks, like what the vaccination rates were in Ohio, and they're mirrored in a lot of states in the United States. And they aren't really high enough for us to be properly insulated against the resurgence of COVID, of some new variant, of some yet unused combination of Greek letters, right? And so what I'm wondering is, we've been talking about nudges and possible ways of persuading vaccine-hesitant people. Like, I guess the question is, will we do better? Will we improve? Will those numbers be better in a year from now or 5 years from now? Or are we just going to continue to see this ongoing cycle of resurgence of COVID cases and, systematic decimation of that unvaccinated population at this point, 95.
So the batteries are so bad.
Yeah.
Do you want this?
No, it came back. It recovered. But something like 95% of people who die in the hospital of COVID are unvaccinated, right? So we know, like, if things stay the way they are, we can see what's going to happen to that population. I guess the question is just, are there ways? Do we have the tools to improve our situation? Will we? Do you think we'll make some progress in? I don't want to say solving, that might be too ambitious, but improving the situation compared to the pandemic over the next few years.
Yeah, I'm glad you didn't use the word solve, because I don't think it's a one and done fix. I think we've become smarter at how we will do the next phase of nudges or incentives or messaging. I think we've learned. Now, going back to your comment of percentages, will that change the percentage by 1 to 2%? I hope so. Will that 1 to 2% make a difference in Ohio? Probably not at a large scale, but for that individual in the community that has the least amount of vaccinated individuals, yes it will. So, as a pharmacist, I'm a grassroots thinker. As a public health practitioner, I go 5,000 feet. So, I think the answer is yes to both. That we become smarter on the large scale, and then at the grassroots, anything we do large scale, we'll move the needle ever so slightly at that level, but at someone at a one-to-one level, it will change a person's life.
And at scale, 1, 2, 3%, you're still talking about millions of people. Correct. Scale. So I don't think we should dismiss these small gains. It's also too hard to do this if you can't celebrate small wins. It's too hard. So if I see that someone has made the choice to do it, fantastic.
I'm happy to get in on that.
Okay. Yeah, that was an oddly somewhat optimistic note for this, for this talk, so it's a good time. Please join me in thanking our panelists.